Welcome to the deep dive. You know how sometimes you just need the essentials on a key medical topic? Well, today we're tackling hepatitis B. Maybe not the first thing that springs to mind, but honestly, understanding this is so important for anyone in healthcare, especially if you're prepping for the MSRA.
Absolutely. Consider this your high-yield study session. We're taking all these notes and boiling them down to what you really need to know and remember about Hep B.
Yeah, exactly. We'll cover the basics, transmission, complications, the whole picture, really.
Hold from various revision sources to give you that clear, efficient overview.
And just think about this for a sec. Hundreds of millions globally have chronic Hep B. It's huge. That alone shows why we need to get this.
Definitely put it into perspective.
Okay, so let's dive in. Definition first. Hepatitis B, what is it? Simply.
Okay, so basically it's a liver infection caused by a virus. The hepatitis B virus or HBV.
HBV. And that's a DNA virus, right? Double-stranded.
That's the one. Double-stranded DNA virus. Key point to remember.
And how does it actually, get around transmission?
It spreads through infected blood and other body fluids. So think sexual contact, sharing needles, that kind of percutaneous or permucosal exposure, and sometimes mother to child at birth.
Right. And it's not always the same presentation, is it? It can be quite varied.
Hugely varied. It can be completely silent, no symptoms at all, or it can lead to really severe stuff like cirrhosis, liver failure.
And I remember reading age is a big factor.
Oh, massively. Getting infected as a baby perinatally is the riskiest time for it developing into a chronic, lifelong infection. Much higher chance than getting it as an adult.
Okay. And once exposed, how long until symptoms might show up? The incubation period.
It's quite a wide window, actually, anywhere from about 6 weeks up to maybe 20 weeks.
6 to 20 weeks. And in the UK, doctors have to report this, right?
Yes, it's a notifiable disease, important for tracking and public health.
And those long-term consequences can be really serious.
They can be, unfortunately. Chronic inflammation can lead to cirrhosis, liver failure, even liver cancer, hepatocellular carcinoma, or HCC.
Okay, got the definition. Etiology, the cause. Pretty straightforward, I guess.
Yep, it's the hepatitis B virus, HBV. That's the direct cause.
And just to hammer it home how it spreads.
Infected blood, semen, other body fluids. So unprotected sex, sharing needles for drug use, and that mother-to-child route during birth are the big ones.
Got it. So who's particularly at risk then?
Well, the key risk factors are unprotected sex, especially with multiple partners, IV drug use with shared equipment, being born to a mother with HBV.
Okay.
Also, occupational exposure, like for healthcare workers potentially handling blood and living in or traveling to areas where Hep B is really common.
Right. Okay, let's get into the pathophysiology. What's actually happening in the liver when this virus gets in?
So the virus basically targets the liver cells, the hepatocytes. It gets inside them and starts replicating. And then the body's immune system kicks in to fight it. But it's this immune response, the inflammation it causes, that actually damages the liver tissue.
Ah, so it's a bit of a double-edged sword, the immune response. Trying to help, but also causing damage.
Exactly that. It's essential for clearing an acute infection, but if it doesn't switch off properly, it can drive that chronic inflammation and long-term damage.
And this is where understanding the blood tests of serology becomes so critical, all those antigens and antibodies.
Absolutely fundamental. Serology is how we diagnose it, figure out the stage, acute, chronic, resolved, immune. It tells the whole story.
Okay, let's break these down. They can be tricky. First one, HBsAg, surface antigen. What's the key takeaway?
HBsAg thanks us for surface and also shows up first. It means the virus is present, active infection. If it's there for less than 6 months, it's acute. More than 6 months, it's chronic. Simple as that, really. HBsAg positive means infected.
Virus present. Got it. What about anti-HBs? Antibody to the surface antigen.
Right. Anti-HBs think anti, meaning against the surface, and it signifies immunity, your shield. You get this either after clearing the infection naturally or after successful vaccination.
Okay.
Crucially, you don't have anti-HBs if you have chronic infection because your body hasn't managed to get rid of the surface antigen. So anti-HBs means immune.
Immune shield. Makes sense.
Yes.
Anti-HBC, antibody to the core antigen. What does this one tell us?
Anti-HBC thinks C for core and contacted. This means you've encountered the virus at some point, either now or in the past. It doesn't tell you when on its own or if you're immune.
Right.
There are two types, IgM and IgG. IgM anti-HBC suggests a recent infection, usually acute think-M for months or momentary. IgG anti-HBC hangs around long term, indicating past infection, whether resolved or chronic. Think G for gone or going on.
Okay, so anti-HBC means exposure, IgM recent, IgG past or ongoing. And the last one, HBA, the ease antigen.
HBA, think E for extra infectious or evidence of replication. If this is positive, it generally means the virus is replicating actively and the person has high levels of virus and is more infectious to others.
Extra infectious, that's a good way to remember it. Okay, these mnemonics help. Can we quickly run through some typical results, like someone successfully vaccinated?
Sure. Vaccinated person, they'll have anti-HBs positive, they've got the shield. Everything else, HBsAg, anti-HBC, HBsE should be negative. No virus, no past infection.
Perfect. What about someone who had Hep B, say, a year ago, cleared it, not a carrier?
Okay, so they had the infection, meaning anti-HBC, specifically IgG, will be positive. They cleared it and are immune, so anti-HBs will also be positive. But crucially, HBsAg will be negative. No active virus now.
Right, so evidence of past encounter and immunity, but no current virus. Okay, final scenario.
Yeah.
Someone with chronic Hep B, a carrier.
Chronic carrier. They had the infection, so anti-HBC, IgG will be positive. The virus is still there, so HBsAg is positive. That's the definition of chronic, 6 months. And because the virus is still there, they won't have developed the anti-HBs immunity shield, so anti-HBs is negative. HBAg might be positive or negative depending on their specific phase.
That clarifies it brilliantly, thanks. So if someone comes in with liver problems, besides Hep B, what else should be on the list, the differential diagnosis?
Good question. You need to think broadly. Other viral hepatitis A, C, D, E. Then there's autoimmune hepatitis, where the body attacks its own liver. Drug-induced liver injury is a big one, too. And other causes of liver dysfunction generally need ruling out.
Okay, now let's talk numbers. Epidemiology. How common is Hep B here in the UK versus globally?
Well, in the UK, thankfully, it's relatively rare now, largely due to the childhood vaccination program. Most cases we see are often in people who've migrated from high-prevalence countries or associated with specific risk behaviors.
And the main risk groups within the UK?
People originally from those high-prevalence areas, individuals with multiple sexual partners, people who inject drugs, and sometimes healthcare workers, though that's less common with precautions.
And globally, you mentioned it's a huge issue.
Massive. The WHO estimated over 296 million people living with chronic Hep B back in 2019. It's particularly high in places like sub-Saharan Africa, large parts of Asia, and the Pacific Islands.
Wow, 296 million.
Yeah.
How does the UK prevalence figure compare again?
It's estimated around 1 in 350 people in the UK has chronic Hep B, but that number's falling thanks to vaccination. And interestingly, most new acute infections here are now linked to drug use or sexual transmission.
Okay, so clinical features. What might someone actually experience if they get hepatitis B symptoms?
It's tricky because, as we said, maybe 70% of acute infections are actually asymptomatic, no symptoms at all.
Right.
For those who do get symptoms, it can be things like fever, just feeling generally unwell, tired, malaise, joint pain, sometimes a rash, jaundice, the yellowing. That only happens in a minority of acute cases.
So it can be really subtle or even silent.
Exactly. Very rarely, it can cause fulminant hepatic necrosis, which is sudden, severe liver failure, but that's rare, maybe 1%. More often, initial symptoms might be loss of appetite, feeling sick, maybe some discomfort in the upper right abdomen, a mild fever, perhaps. Sometimes people get this profound malaise, just feeling wiped out, and maybe an aversion to things like smoking or alcohol. If jaundice develops, urine might get dark, stools pale. In really severe cases, you might see signs of the liver failing, fluid buildup, ascites, confusion, encephalopathy, bleeding issues.
That covers acute. What about chronic hepatitis B? How does that usually look?
So chronic Hep B means HBsAg is positive for over 6 months. It's a real spectrum. Could be an inactive carrier state with low virus levels, minimal damage, or it could be progressive disease leading to fibrosis, cirrhosis, and that increased risk of liver cancer, HCC.
And progression relates to the virus level.
Yeah. HBV DNA levels are key. We also classify it as HBsAg positive or negative, which affects management. Symptoms in chronic disease, if present, are often quite nonspecific: fatigue, maybe some nausea, anorexia, right upper quadrant discomfort. And remember, the risk of progression is higher if infected young, and the HCC risk is significantly up in chronic cases.
And just to quickly revisit transmission routes?
Sure. Parenteral blood and body fluids. So sexual contact, IV drug use, sharing needles, mother to baby at birth, perinatal, and potentially occupational exposure. Blood transfusion risk is tiny now in the UK due to screening.
And patterns differ globally.
Yeah, high prevalence areas often see more childhood transmission, whereas here in the UK, it's more commonly acquired in adulthood through sex or drug use.
Okay, investigations. Someone comes in, you suspect Hep B. What tests do you order first?
Standard initial bloods are key. Liver function tests, LFTs, full blood count, FBC, urea and electrolytes, UNEs, and a clotting screen, coagulation profile. But the specific diagnosis hinges on those viral markers, HBsAg and anti-HBC.
Right. And when do these markers typically appear?
HBsAg usually shows up about 4 weeks after exposure. If it's still there after 6 months, that's your definition of chronic. Anti-HBs, the immunity marker, appears weeks after recovery or post-vaccination.
And anti-HBC.
That indicates exposure past or present, useful for screening contacts, too. Then you've got HBAg for infectivity, and measuring the HBV DNA level itself helps decide on treatment and monitor response.
Any other tests you might use? Imaging.
Yeah, definitely. An abdominal ultrasound gives a good look at the liver structure. If HCC is suspected, you might go for a CT or MRI. For chronic cases, we often assess liver scarring using transient elastography like FibroScan or sometimes a liver biopsy.
Biopsy less common now with FibroScan.
Often, yes.
Yeah.
We also use alpha-fetoprotein, AFP blood test for HCC screening in high-risk patients, and it's crucial to test for co-infections like HIV, Hep C, and Hep D as they can change the management plan.
Okay, we have a diagnosis. Let's talk management. What's the general advice?
Education is key. For the patient, their contacts. Making sure everyone understands transmission, prevention, like vaccinating contacts and the long-term possibilities. Advise avoiding unprotected sex until things are clear or partners are immune. And definitely no blood donation.
Makes sense. What about treating an acute infection?
It really depends on severity. Severe cases need hospital admission. Milder ones can often be managed in primary care. Confirm with serology, obviously. If HBsAg is positive, refer to a specialist.
And treatment itself.
Mostly supportive. Fluids, maybe anti-sickness meds, rest. Avoid alcohol until LFTs normalize. Review their other meds. Cool compresses for itching. Antivirals are rarely needed for acute Hep B unless it's progressing to that rare fulminant liver failure.
Right. And for chronic infection, how do you assess and manage that?
For anyone HBsAg positive, you need more tests. HBAg status, HBV DNA level, detailed LFTs, ALT, AST, GGT, albumin, etc., FBC, clotting, plus that liver ultrasound and AFP for cancer surveillance.
And referrals pretty standard for chronic cases.
Yes, all HBs-positive adults should be referred to a hepatologist or specialist for a full assessment and management plan. Pregnant women who are HBsAg positive need specialist input too, potentially for antiviral treatment in the 3rd trimester to reduce transmission risk.
When is immediate referral needed?
Any signs of decompensated liver disease, jaundice, ascites, encephalopathy that needs immediate specialist attention, and kids with Hep B need a pediatric specialist.
What about the actual drugs for chronic Hep B?
It depends. For HBAg-positive patients with compensated liver disease, first line is often interferon alpha-2A. If that doesn't work, tenofovir disoproxil is an option.
And if they're HBAg negative?
P-interferon is still first line. Alternatives include entecavir or tenofovir disoproxil.
What about pregnancy or breastfeeding?
Tenofovir disoproxil is the preferred choice then, specifically to cut transmission risk.
And if someone needs immunosuppression, like for chemo or autoimmune disease?
If they're HBsAg positive with significant virus levels, as BV-DNA 2000, they usually need prophylactic antivirals like entecavir or tenofovir to stop the Hep B flaring up. Lamivudine might be okay for short courses, but the others are preferred for longer-term immunosuppression.
What if someone has chronic Hep B but doesn't meet criteria for treatment right now? How are they monitored?
Still need regular monitoring. Depends on the phase. Immune-tolerant phase. Monitor ALT. Inactive chronic phase. Monitor ALT and HBV DNA regularly. If they have cirrhosis, monitoring needs to be much more frequent due to the higher risk of complications like HCC.
And if someone has HIV as well, co-infection?
That complicates things. Liver disease can progress faster. There's also a higher risk of liver toxicity from HIV meds, so treatment choices need to balance liver disease severity and their CD4 count.
Vaccination has obviously been huge.
Absolutely massive. Routine childhood vaccination is standard in the UK. Plus, we recommend it for all those high-risk groups: healthcare workers, IV drug users, contacts of cases, people needing blood products, chronic kidney disease patients.
And the vaccine itself?
It's typically the HBsAg protein made using recombinant DNA technology absorbed onto aluminum hydroxide. Very safe and effective for most people.
Some adults don't respond fully first time, though.
That's right. Some might need extra doses to get adequate protection.
So, summing up management meds-wise.
Severe acute disease might get antivirals, entecavir-tenofovir, until HBsAg clears. Chronic infection. Antivirals, entecavir, tenofovir, or pigeon interferon are considered, even without cirrhosis. Treatment duration varies. Sometimes the goal is complete HBsAg loss.
And non-medication management.
Most acute cases just need supportive care. But if it becomes severe liver failure, antivirals and assessment for liver transplant are vital. Chronically infected patients also need ongoing assessment for potential transplant need down the line.
Okay, one last detail. Interpreting anti-HBs levels after vaccination. What do the numbers mean?
Good one. 100 MI/UML. Great response. Usually no more testing needed, maybe a booster after 5 years for some high-risk groups.
And if it's lower, say 10 to 100.
That's suboptimal. Give 1 extra dose. Usually fine after that for immunocompetent people.
And less than 10. Non-responder.
Yep, 10 is a non-responder. First, check they don't actually have current or past infection. If not, repeat the entire vaccine course. Still no response after a second course. Then they might need HBIG hepatitis B immunoglobulin for protection if they have a significant exposure.
Got it. Okay, prognosis. What's the general outlook?
For acute Hep B in healthy adults, it's generally good, most clear spontaneously. But chronic infection is the real worry. That carries the risk of those serious long-term issues: cirrhosis, liver failure, liver cancer.
So early diagnosis and management are key.
Absolutely crucial. They significantly improve outcomes and cut the risk of complications. That's why screening high-risk groups is so important. Find it early, manage it properly.
And prevention.
Vaccination is #1 for preventing new infections in those not immune. And anyone with chronic Hep B needs specialist referral for ongoing therapy and care.
What about managing contacts, sexual partners, needle sharers?
Contact tracing is vital. Notify them, offer testing, and vaccinate if they're not immune. And for babies born to infected mothers, vaccine right at birth.
You mentioned specific pregnancy recommendations.
Yes. All babies born to infected moms get the vaccine soon after birth. If the mother has very high viral load, high HBV DNA, the baby should get both the vaccine and HBIG immunoglobulin at birth in different sites. That combo slashes transmission risk by about 90%.
Okay. Lastly, complications. We've touched on them, but let's list the main ones.
The big long-term ones are cirrhosis and hepatocellular carcinoma, HCC, from chronic infection, close monitoring needed.
And other potential issues.
Chronic hepatitis developing from acute, 5–10%. That rare but severe fulminant liver failure in acute infection, around 1%. Kidney issues like glomerulonephritis, and some rarer extrahepatic things like polyarteritis nodosa, blood vessel inflammation, and cryoglobulinemia.
And HCC surveillance is recommended for certain groups.
Yes, definitely for those with significant fibrosis or cirrhosis. Typically involves 6-monthly liver ultrasound and AFP blood test.
What about people without cirrhosis?
Might still consider surveillance if they have other risk factors like being over 40, family history of HCC, and high HBV DNA levels, say 20,000 IU/ml, but generally not recommended for younger people with lower DNA levels and no significant scarring.
Right. This has been incredibly comprehensive. A real deep dive. Key takeaways.
Understand the transmission routes. Know how to interpret that serology HBsAg means infection, anti-HBs means immunity, anti-HBC means contact. Remember the spectrum from acute to chronic and the serious risks like cirrhosis and HCC with chronic disease. And know the management basics: supportive care for most acute, antivirals and specialist monitoring for chronic, and vaccination for prevention.
Absolutely vital stuff. Okay, a final thought to ponder. How do you think global travel and migration patterns are changing the face of hepatitis B epidemiology, even in low-prevalence countries like the UK? Something to reflect on.
That's a really interesting point for ongoing consideration.
Definitely. Now, if you want more resources like this to absolutely nail your MSRA, head over to PassTheMSRA.com.
And for loads of free content, questions, and support, check out freemsra.com.
Thanks for joining us for this deep dive into hepatitis B.